Well, welcome everybody to the first of 2026 Optometric Education Consultants National Webinar Series on a Sunday night edition. Tonight's topic is macular dystrophies and more, diagnosis and management with Dr. Chris Putnam. He got his doctorate from Pacific University. He was then commissioned in the United States Air Force as part of the Health Profession Scholarship Program. He completed a residency program at Wilford Hall Medical Center and was awarded board certification in 2009. He completed his PhD in vision science at the University of Missouri St. Louis in 2014, and he is currently serving as a commander for the 8th Healthcare Operations Squad at RAF Laken Heath, I'm sorry. And he is coming to us tonight. It's 12:30 in the morning his time in the UK. So please, a nice warm OEC welcome for Dr. Chris Putnam. Chris, please take it away. I'm looking forward to it. Your presentations are always outstanding, always insightful, and especially well researched. So I am looking forward to this. So please take it away.
Yes, sir. So hopefully everyone can good morning, if you will, from outside of London, UK. So thank you again, Joe and Greg, for this opportunity. I don't sleep much anyway, so this is right on my normal circadian rhythm. Hoping to get into some of the details here today, and I am a primary care optometrist by training. So my biggest takeaway that I hope I can give today is the value of a clinical practice guideline and how to look at macular dystrophies and more, including some of the white dot syndromes, on how in a primary care environment can you use what you already have to help make differential diagnoses and make your clinical decision making a little bit more streamlined. So I was already introduced by Joe. That was very flattering. There is my background just a little bit. So I am a Minnesota kid who went to South Dakota State for a 4-year stint in chemistry many years ago. As Joe did mention, I am still active duty, so this is my shameless plug for the Air Force optometry realm. We are currently about 80% manned, so if you have any friends, family, or you would like to consider a career in the United States Air Force, you can always use me as a liaison. I'll be happy to tell you about the good, the bad, and the ugly of U.S. Air Force service. So, kicking it right off and following Greg's lead on this one, what I'd like to do is just test out the polling process for everyone on your end. First question, how confident do you feel in the clinical discrimination of macular dystrophies and white dot syndromes? Can let everyone mull that over for one moment.
Chris, I've always said that in retina, academically, if one doesn't know what they're looking at, it generally just defaults to a white dot syndrome of some sort.
And you are absolutely correct with that. It gets very Venn diagram-ish, if that's a term. And so I'm going to actually kind of walk through some of those small little nuances that can help a primary care clinician make some good, accurate differentials and then excellent referral and timely management decisions. And I will hand those out today, and anyone can reach out to me. I'll have my contact information at the very end of the webinar as well.
And I can tell you, everyone out there, I put in the polling questions. This is probably the easiest one. You will definitely be board certified once you go through the other 4 questions. So I think your PhD was coming out on that one, Chris, on the other ones.
Yeah, apologies. I am a nerd at heart, and sometimes I have a tough time masking that.
All right, let's see here. Looks like we got a nice little trend going on here. So we have, I'll display the answer. We have 2% saying highly. We have 41% going moderate. Right down the line, 52% is going with low. And then we have 5% going, what's a white dot syndrome? So I think we're going to do well here tonight to try and help differentiate out these white dots, because there's a low confidence to what is a white dot syndrome.
Absolutely. And so with that, We'll dive right in, and this is meant to be an information dense presentation. These are slides that you can absolutely use as a reference source. But at the end, what I'll do is there will be one-page handouts for both macular dystrophies and white dot syndromes, along with an accompanying clinical practice guideline that is built from not only the AAO website, but also from peer-reviewed review articles. Because as Joe mentioned, I have a lot of time on my hands, so I like to try to distill things down from a academic sense, but I'm a clinician at heart as well. So I like to have very meaningful, easy to implement type of clinical practice guidelines because all of us tend to have, you're going to have 20, 30 minutes with that patient, maybe tops, and you need to keep the process moving. And the only way to do that is to have everything kind of preloaded and chambered and ready so you can continue to make good clinical decisions in a timely manner. So this very first slide is meant to be an overwhelming slide because you can see how very complex and how very nuanced macular dystrophies are. And so you'll see on that right side, there's going to be a number of these different dystrophies that present very, very similar to one another, but they're small little discriminators, small little differentiators early in the process that, frankly, using what you already have in your clinic will be a very, very almost welcomed way forward. Because once you start putting all the pieces to the puzzle, I was an Encyclopedia Brown reader when I was a kid, and that was always my favorite part, is put the clues together and figure out what you're dealing with. And so here is really kind of the question. So when we look at macular dystrophies, and then as we move into the white dot syndromes, the current classification approaches usually range from inheritance down to macular appearance, the pathophysiology, and the anatomic location. And it's important to know that each one of these has its own value, but the true, real singularity in that is when you can encompass value or the most important aspects of each one of those and take kind of a gestalt view on that. And so that is why you will see on the clinical practice guideline and the comparison table, these are snapshots that you can use. I'm also clinical faculty at the University Incarnate Word in San Antonio. And so this is what we use with our third and fourth year students as well, is how to make good clinical decisions in a rapid fashion. We'll also talk about IRDs, or the inherited retinal dystrophies. There is a number of different testing opportunities out there. If you are a lover of lab testing and genomic testing, these things do exist out there, but we'll talk about some of the pitfalls and some of the best clinical practices, because I won't do a spoiler alert and talk too much about them now. But when you're doing inherited retinal dystrophy testing, especially on the genomic side, it's critically important to make sure you have either a genetic counselor involved in that, or you have a plan of action for what you might find. Because if you throw the kitchen sink against the wall, you can see that there's going to be a lot of overlap in these conditions, and you may find that there is an allele that is found in a number of these different dystrophies, and the simple presence of that allele does not necessarily make the diagnosis. So it's critical to use all of our clinical acumen and all of our clinical decision tools to help get to the right answer, and at the very least, how to manage and refer some of these patients to ensure that there is not long-term vision loss. And here again, entirely complex, but this is in reference to what I just mentioned. If you look at some of the alleles out there, it would be nice to have a simple 23andMe or a very nice Ancestry.com, if you will, cheek swab. I spit in a tube, I send it in, and Gattaca style, I know exactly what my future holds. But unfortunately, the human body and a lot of these pathophysiologic processes are interwoven and highly complex. So as you can see on that graphic on the left, there's that Venn diagram that I mentioned. So when you're discussing Leber's congenital amaurosis, when you're talking about some of the macular dystrophies, when you get into some of the cone rod dystrophies, a lot of those alleles have a lot of crossover and a lot of similarities. So it's not just as simple as do a genetic test, here's our answer, here's our management, because there's a significant amount of crossover. And if you are a reader at home, probably Gregor Mendel rolled in his grave a number of years ago because there was an interesting article that came out. It's been a few years back now that there was some hyperbole from a UK researcher that suggested that Gregor Mendel fudged his data, that there was no way that the green and the yellow pea experiment that is the fundamental to our Punnett square that we all learned in undergrad, there's no way that data could have been that clear. But in fact, there was a nice article, it was already in 2016, and there's a couple books out there that in fact, given the technology at the time, that data does still hold water even a century later. But the reason that I say that part of the critical challenge of doing a macular dystrophy diagnosis is autosomal dominant versus autosomal recessive. Yes, there are inheritance patterns that taking a good family history and a really good family history of not just first degree relatives, but second degree relatives, knowing if an aunt or an uncle or a niece or a nephew or a someone outside that straight family tree has significant vision loss can help make your diagnosis. But at the same time, variable expression plays a role out there, and you can have de novo mutations that did not exist in a previous generation, but through epigenetic and some incomplete penetrance factors, it may manifest. Although it was present, but just not symptomatic in mom or dad, it may in fact be significantly more symptomatic in the daughter or the son. So the family history is a great place to start, but that is not alone in isolation the key to your next management choice. And just because it wasn't complicated enough, there's also a number of different systemic conditions. So some syndromic conditions that can play a huge role because the eye does not hang in a closet separate from the body. The eye is intimately, and as we all know as optometrists and clinicians, the neurologic, the vascular, a lot of the same processes that you will see presented in systemic conditions will manifest directly in the eye. So it's important that, yes, we're looking at the retina and in particular the macula and the fovea, but taking a complete look at that patient as a whole. What does their gait look like? Do they have any kind of unique presentations? Do you see any anatomic differences in that patient presentation? Pupils, EOMs, just their overall presentation on their facial symmetry can play a big role. And I'll have a case report here in a few moments on this exact topic. And as we mentioned with those 5 classification schemas, yes, you can absolutely look at the pathophysiology that underlies a lot of these things. But if you look at those red arrows, the pathophysiology is also interwoven because you can have protein misfolding. That protein misfolding then secondarily results in phototransduction issues and then oxidative stress, which then results in impaired metabolism, and it becomes almost a perpetual snake feeding on its tail, if you will. So to use a strictly pathophysiologic classification system is also not appropriate because there's a number of different things that can have a secondary effect, and you can see these cross all the way up and down the line on not only the white dot syndromes, but particularly here on the macular dystrophies. And the anatomic portion, especially as an optometrist, we're going to talk a lot about this, but not only from your pre-screening and your screening portions, your fundus autofluorescence and your spectral domain OCT, those are your 2 best friends in any of these macular dystrophies. If you have the ability to pair up fundus autofluorescence along with your spectral domain OCT, you can make a very accurate, very timely diagnosis and help make that referral and help make that management decision in a primary care setting. And that is what the table and the CPGs will hopefully help for today. And interestingly, one of the other things as I researched this a little further, there's a couple conditions that anyone in school, I graduated, it's hard to say, 20 years ago now, we learned things as distinct entities. And a few of these macular dystrophies over the last 20 years, it's found that these are not distinct entities. They're in fact the exact same presentation, and they should be treated as such. And we'll talk about those in one moment. So here is my proposed macular dystrophy rubric. So we'll talk a little bit about this. We'll use a couple case examples and we'll step through this directly. But when you're looking at the demographics and when you're looking at the family ocular history, as you're doing just a normal clinical finding, I think virtually everyone here is going to take best corrected visual acuities. Virtually everyone's going to look at the fundus, but I will offer up color vision testing. And the color vision testing, whatever your cup of tea is, tongue in cheek, because I'm here in the UK, that is certainly your prerogative. But I would say if you are truly going to use a color vision test as a discriminatory decision maker, the HRR is a very, very nice test because the HRR is somewhat unique that it tests right along the 3 lines of color confusion. So you can very accurately, with that plate, identify if there's an overall difference, what that difference is, or if there is a scattered non-specific color. And interesting, people can't cheat very well in this because you can literally rotate the testing plates and you will get an entirely different presentation. So the patient can't necessarily memorize luminance or contrast cues. You can rotate the plate 90 or 180 degrees and you can actually test them again. And it can help tease out some of those very astute patients that are just good at using other visual cues to identify it. And most importantly, probability. I will say that the probability is one of the biggest discriminators out there because you're going to see that prevalence within macular dystrophies is very challenging because prevalence is calculated through incidence and duration. And in some of these cases, they're so very rare that it becomes very difficult to target what the actual prevalence rates are. And we'll talk about that specifically in macular dystrophies, but also as that plays a role in white dot syndromes. And then we're going to tie that all together at the very end. And I will step through each one of these clinical tests and what the peer-reviewed literature tells us about how we should implement these in a primary care setting. So moving right back over to poll number 2, I know it's very wordy, but if you read through there, I think you already know these answers. But why is macular dystrophy classification by inheritance pattern alone difficult?
So Chris, just so you know, the C was a little bit longer, only allowed 140 characters. And
Fair.
so the audience, it's not going to match up. So I had to reword it to make it fit 140 characters.
Oh, that's fair.
So it says variable expression, de novo mutations, epigenetics, and incomplete penetrance drive diverse clinical presentations. So kind of saying the same thing, but
Absolutely.
a little bit shorter.
Sure. And I remember something from grad school and optometry school. If the answer is long, it can't be wrong.
That is the psychometrics, right? It's a long answer, but it's probably the answer. So
Absolutely.
all right. So it looks like we got a nice amount of people rolling in with this one. So I'm going to display the answer. Joe, any questions to this point before I go further? I'm not sure. He might be muted.
Sorry
All
about that. No questions.
Okay. All right. I wasn't watching, so I was watching the poll here. All right. All right. So display. And we went 4%, 10%, 84% with the long answer, and 2%. So 4, 10, 84, and 2.
Very good. So yes, so building on that, it's important to, as I mentioned earlier, I've been Air Force for 20 years. Any good briefing, it begins with, we tell you what we're going to tell you, we're going to tell you, and then we're going to tell you what we told you. So here is kind of an overview on the macular dystrophies. And you'll notice in the yellow on that bottom third, when you're looking at the autosomal dominant drusen or Doyne honeycomb versus Malatia levitinense or levitinense, depending on your persuasion, In fact, those conditions are exactly the same. And I know that probably violates what everybody learned and what everybody was taught. But as you start digging into the literature, it's very interesting that the alleles match up, and a lot of the clinical presentations, although diverse, fall into that kind of realm where those, in fact, are the same clinical entity. And the other important part of why I want to put those in yellow and spend a bit of time on those is because those are also AMD mimics. And when you think of a macular dystrophy, if it's a 15-year-old with significant foveal or macular changes, you're not necessarily thinking age-related macular degeneration. But if you're going to have a 45-year-old or an early 50s patient that has never been seen by you or perhaps has never had an eye exam before, sometimes these AMD mimics can be a little bit challenging. But if you use some of these clinical practice guidelines, you can see that a standard AMD patient doesn't have all of these other clinical signs and symptoms that a true macular dystrophy would, and we will step through those exact things now. So, as I mentioned earlier, it will be an information-dense slide, and this is not meant to memorize, or it is not meant to blow anyone's hair back, so to speak. But what we'll do is every slide will be built in this fashion. And what I'll do is the very first slide, so Stargardt's or fundus flavomaculatus, that is the most prevalent macular dystrophy reported in the literature. So we're going to go down and play that probability game that if you hear hoofbeats, think horses. But as everyone who's ever been in practice for any number of years, you can think horses, but you cannot ignore the zebras because they will trample you. So there is some little cues and tricks that I will walk through here in a moment. And any questions, any concerns, you can always reach out to me later or put them in the chat. And Joe and Greg will I think, be more than happy to interject and let me know where we're at. But what you can see is from a Stargardt's condition, some of the most unique clinical features to this is we're going to see that kind of paramacular flecking that begins to extend to the mid-periphery. And so depending on when that patient presents, the most common time within a lifespan for a Stargardt's to present for vision changes is within that first to second decade. So from a strictly macular dystrophy standpoint, here's where the value lies, is because Stargardt's is not as easily confused with, say, a age-related macular change because it tends to present much earlier than in life than an age-related condition. And you can see that one of the things for Stargardt's that definitely becomes kind of complicated is depending on what group they fall into. So if you go down to that fifth block where it says prognosis, it can be very variable. So they will all fit within that Stargardt's bin, if you will. But you can see that dark adaptation and full field flash ERG can be two important discriminators. And even if these are not devices that you utilize in your clinical practice, I think it's important to understand and know that these devices do exist. And if you have a peer in your area or in your region that does use dark adaptometry and does use the full field ERG, these are very valuable. And the nice thing, and the reason I put dark adaptometry and full field ERG or full field flash ERG out here is because these are now commercially available devices. Because if you remember back to school, dark adaptation was sitting in a closet for 45 minutes. That's not clinically viable. And full field ERG with the old Burian lens, that was a very difficult clinical setup to ever incorporate. But some of these new commercially available clinical devices have normative databases and can help you make an accurate, timely decision in a primary care setting. So from a Stargardt standpoint, what you can also use is, as we mentioned, any macular dystrophy, the two most important parts, because you're going to do your standard routine comprehensive exam, but spectral domain OCT in combination with fundus autofluorescence, those are very critical pieces. And when you start putting those together, you can see how these start to almost complement one another as you're making your diagnosis. So you can see from a Stargardt's sign, that top left is a fundus autofluorescence. If you do use a lot of fundus autofluorescence in your clinic, I applaud that. I think that is fantastic. But fundus autofluorescence, in my humble opinion, is an underutilized tool. And you'll see here in a few slides that utilizing fundus autofluorescence is almost pathognomonic in some of these macular dystrophies. But you can see from the fundus autofluorescence on the left versus the OCT on the right, you can see how you can cue those in because you're not seeing a lot of drusen change. You're not seeing a lot of RPE change. You can start to see what retinal layer is most affected. And then when you bring that back to what the fundus actually looked like, that's when you can start to tie these things together. And in the interest of time, I'll move through some of these slides fairly quickly, but I will get to the table and the clinical practice guideline, and will we use 3 case reports to step through in a checklist manner how to make these things happen.
Hey, Chris, can you go back one slide? I
Of
just want to
course.
know what you were showing with those 2 columns of pictures. They're great pictures. Just trying to figure out. Let's go. Let me see what slides you're on. I'm on watching the presenter's side. Go back one more.
One more, you bet.
Yeah, these 2 columns here, you have the photos. It looks like you have a fundus autofluorescent and an OCT. Is there any difference between the left column and the right column?
No, so those are essentially just 2 different patients that presented with that. So this one, I did utilize this image from a peer-reviewed article. So at the very end, I'll have the bibliography, but that's kind of the challenge as well, is because if you receive a case report and you don't know what it is, sometimes it can be difficult to know whether that's an infrared imaging or whether that's a fundus autofluorescence. And a rule of thumb, if you're looking if it's fundus autofluorescence versus an infrared imaging, fundus autofluorescence typically has a glow to it. And when you look at the fovea and the optic nerve head, there is no lipofuscin typically at those locations. So the optic nerve head in a fundus autofluorescence should be pitch black. And in an infrared imaging, because of reflectance differences, you can see some changes at the optic nerve head. So a fundus autofluorescence has a glow, has a pitch black nerve, and you should see diminution at the fovea where the macular pigment is absorbing that wavelength, and it should be a dark foveal center.
And then one little clinical pearl for the audience out there, when we talk fundus autofluorescence, is that it's basically targeting the RPE. It's not inner retina, it's not outer retina. It's basically determining the health of the RPE. So I just didn't know those are 2 different patients there. That clarified it. Thank you.
Yes, 2 different patients. That's a great point, Greg. Yeah, the RPE is exactly what fundus autofluorescence is looking for, because what it's doing is it's causing a fluorescence of the lipofuscin, which is deposited with the RPE, and specifically the A2E fluorophore is what causes that fluorescent glow. So that's why a fundus autofluorescence will have almost a glow in the background. Absolutely good point. Very good point. So then if we use the prevalence and probability, we talked Stargardt's is our number 1. And then when we move to pattern dystrophies, prevalence is about 1 in 10,000. Again, based on rarity, these are just, I hate to say wags, but these are really tough to pin down because of the rarity. But the pattern dystrophies are somewhat unique because if you get down into not only when they present, pattern dystrophies don't tend to present until that 30s or 40s, but also diagnostically, they don't tend to have significant visual effects, meaning your best corrected visual acuity in a pattern dystrophy doesn't tend to go to the 2120 or the 2200 Snellen. You tend to have relatively normal best corrected visual acuity and relatively normal color vision as well. So that's one of those nice little cues early on that if you have significant vision loss and significant color vision changes, it's probably not a pattern dystrophy. It's more likely a different macular dystrophy, and we will cover that in the chart. And then finally on this one, from a management and prognosis standpoint, these are the patients that to my knowledge and within the literature, there's not a very well-defined management process on these. It's mostly monitoring to ensure that a CNVM or a neovascular development doesn't begin to threaten vision long term. And you can also see from a pattern dystrophy, the dark adaptation and the full field ERG also tend to be relatively normal. And I'll have a case report on a patient just like this here in a moment. And so pattern dystrophies, if you mentioned or saw the last slide, there's also 5 distinct entities, but they can be grouped under a pattern dystrophy. And we could go into detail on each of the 5 variants, but from a primary care standpoint, the real important part is to know, is this a progressive cone dystrophy or is this a pattern dystrophy? And having some of these ideas that if it's a pattern dystrophy, you can breathe a bit of a sigh of relief because symptomatically, from a patient prognosis and management, they don't tend to have that severe long-term vision loss. And so if you're looking at the pattern dystrophies on the left versus the right graphic, same type of thing. It's a very striking retinal appearance, but with that striking retinal appearance, a pattern dystrophy in general, not always, but in general, tends to have relatively preserved best corrected visual acuity. So that's one of the keys and cues you can look at if a 45-year-old Hispanic male presents and you look at this, it looks like a striking macular change. But if their vision is well preserved and they don't have a systemic or a metabolic underpinning, they don't have a history of any other eye conditions, these are some of the clinical cues that on the practice guideline and the template, we'll talk through those in a moment. So then moving into the next most common retinal dystrophy, this is a
Hey, Chris, let me ask a question here real quick, just because I want you to go through this, but I want you to, this is a question for me, not really from the audience, is that I think, I do a lecture called Complications of Pharmaceuticals Every Optometrist Should Know. So obviously Plaquenil can cause an RPE type of loss, outer retina type of loss. There's also pentosan polysulfate, Elmeron, I think is what it is. It can cause a pigmentary maculopathy. So we have these pattern dystrophies, we have these genetic dystrophies, we're gonna have some white dots, but there's also medications that can cause it. Is it the symmetry that happens with the dystrophies that kind of helps you set aside, like, say, maybe the pharmaceutical complications? Like, how can we, separate out the complications of pharmaceuticals that can happen with these from these medications to what you're talking about tonight? Is there an easy way, or is there a thought process that you have to that question?
Absolutely. And that's a very good question. It's starting probably in my practice at the very beginning when I'm doing the case history. So as you mentioned, from a Plaquenil or hydroxychloroquine, when you start getting into those, if they don't have a rheumatologic condition and they're not on a DMARD or a disease modifying anti-rheumatic agent, or they're not on a Plaquenil, that helps rule some of that out. And depending on what their systemic history is, absolutely right. It's also probably important to think about, when did the visual effects or when did these things start to present? Because if they were started on a medication, if there is any way to identify, were there vision changes prior to the medication use? Were there any retinal changes prior to the medication use? And then comparing the post-medication start, that's probably the easiest way. But Greg, you're absolutely right. If you don't know these answers, if you don't know, you have no baseline retinal appearance, you don't know the patient, sometimes we're our own worst historians. If you don't know when these vision changes started, they can absolutely mimic one another. And a lot of times too, and we'll talk about the flying saucer sign, so that was a perfect segue. The changes to not only their color vision, but also some of their fundus autofluorescence paired with their spectral domain OCT will start to show little discriminators, because with the medications, there tend to be not very, but highly specific changes to the retinal appearance, and they can be slightly different. But you're absolutely right. That will be up to the clinical acumen, and that will take some experience and some additional testing, like full field ERG and some of the dark optometry, to identify, is it the outer retinal layer changes, or is there something else that's causing this retinal appearance change? But that's a very good question.
Hey, Chris, there are a couple of questions that just rolled in, which are very good questions. Which retinal layer is typically affected in plaquenil maculopathy is the first question.
That one is going to tend to be the outer retinal layers. So that's when you start to get those losses of the photoreceptor and the outer retinal layer. And I'll actually have a case report in a moment that if you've seen the flying saucer sign, what happens is you have that normal foveal appearance. So if you go to the very bottom right, it's not a perfectly normal fovea, but you can see on that very bottom right graphic, you start to have that foveal pit, that foveal depression that kind of sinks in. When you see a plaquenil, the outer retinal layer on the outside of the fovea, so the outside of the foveal pit begins to thin down. So you have almost a thicker central foveal pit and it thins down outside the foveal layers. So in a plaquenil concern, you start to look at what that SD-OCT is. But in general, too, plaquenil toxicity over the last few years, I would even say the last 10 to 12 years, is significantly lower than it used to be with the strict prescribing guidelines and based on weight and gender and essentially what the pre-existing kidney and liver function is for that patient. Plaquenil toxicity, unless they have been using it for 25 years or at very high doses, um, is a concern, but I would rule everything else out before I went to plaquenil toxicity.
And Chris, if a person has a pre-existing macular dystrophy, would you advise against plaquenil usage?
That's a really good question. I think that is going to come down to two things. It's going to come down to discussing other options with the rheumatologist or the immunologist or who's managing that if there already is a metabolic strain, oxidative stress on the retina, if the retinal layers are already, let's say, less than optimally functional, I think that would come down to a discussion. Are there other options for the patient? But at the end of the day, if the rheumatologist, immunologist, if the managing physician absolutely insists that the plaquenil must be on that patient's board of menu or menu of medications, I think that's when you have to make that kind of risk-based assessment, then monitor them even closely at a more 3 to 6 month. And if there's any changes early, that is when you'd have to get into a serious discussion with the managing provider.
You see, I think, Chris, I myself would not advise against it, but then again, I'm not prescribing the Plaquenil. I've probably had the same number of patients tell me, I really didn't get much out of Plaquenil versus the patients who say, this is the only thing that works for me.
Absolutely.
Now, I don't know that I am of the opinion that they are at more risk. But this is the reason why a person, when a person is put on Plaquenil, we need to do all the baseline testing. For the simple reason, we're not expecting to find Plaquenil toxicity after a month of use, but we need to know what was there to begin with.
No, and that's a very good point. And I think that the landscape is even going to further change as more of the biologics become available in more formularies. I think as you start to see some of these newer treatments in some of these rheumatologic factors, I think that Plaquenil use is imperative now, but I think that there will be more and more options for some of those autoimmune and collagen vascular patients in the future. Absolutely.
Chris, regarding the Plaquenil, what layer? This is what I have in my head that happens, and can you confirm or correct my thinking? Is that it builds up in the RPE to a high levels. It has a tough time being metabolized and turned over, so it reaches a toxic level, but then it kills the outer retina. So it's not really an RPE, but it builds up there. But then the toxicity occurs to the photoreceptor into that kind of outer retina, but it's the buildup in the RPE is what I have in my head. Is that correctly a thinking?
Absolutely. That is also, I think, the shared understanding in the peer literature. And I think that's actually a very easy kind of corollary to that's a majority of the photoreceptor and the outer retinal layer conditions is because the RPE acts as the metabolic substrate to the outer retinal layer. Because the outer retinal layer receives its metabolic support from the RPE as opposed to the inner retinal layers where you have the central retinal artery supply. When the RPE essentially has some metabolic dysfunction, when the RPE is having really just dysfunction in general, you absolutely start to see that first without visual symptoms, without sensory retinal changes. But as that RPE begins to form more and more dysfunction, because it's supporting that photoreceptor and that outer retinal layer, that's when you start to see that diminution. That's when you start to see those changes in the outer retinal layer because the RPE is sick and not functioning well. That's my understanding as well.
Perfect. Thank you.
Sir. So Best disease, I do put Best vitelliform macular dystrophy and the autosomal recessive Best retinopathy into kind of a subcategory, but yet a different category because Best disease, I think we're all familiar with the egg yolk and then the scrambled egg, and then you have the significant atrophy that follows. But there's an interesting little variant in there that depending on when it presents, if it presents very early in life, say during your teens or 20s, that tends to follow a more it tends to follow a little bit more contemporary or more understood pathway from what we were taught in school, that is the best retinopathy. That's the best vitelliform macular dystrophy that we're familiar with. However, there is a variant that can present essentially in your 30s, 40s, and even early 60s in some cases, and that tends to be a little bit more of the autosomal recessive condition. So this one is the third most common prevalent macular dystrophy out there. And so this one, I think, becomes a little bit challenging because as that patient ages, like all of us, you have a little bit more complications and more potential conditions for what could be causing some of those retinal changes. So speaking strictly from a vitelliform macular dystrophy, in the early stages, you tend to have a relatively normal visual acuity, and you tend to have mild but odd, strange HRR where they're crossing color confusion lines, and it doesn't follow a true protan or deutan change to the color vision. So a lot of times too that we had talked a little bit about dark adaptation and full field ERG. Here's the point where even with your fundus autofluorescence, even with your OCT, sometimes having just at least a peer or an ability to do some of those additional ancillary tests can help rule that out because that retina is going to look funky. You're like, it's not fitting into a bin neatly. But if you can start to use the checklist that we'll talk about in a moment, and you start to use the table for where the most likely changes lie, I think that's when you can utilize this to its fullest in the case of Best disease. And when you go down to the prognosis, this is usually, again, just like anything else, it can change. Patients are entitled to as many darn conditions as they darn well please, and you can have a lot of kind of interesting synergistic and negatively affecting factors, but the staging becomes important. And when you start to see the visual changes, that's when you need to start looking very, very closely for those choroidal neovascular changes. And that you'll find in a lot of these slides is when you have a macular dystrophy, it's really just ruling out, is there enough atrophy? Is there enough loss of normal retinal circulatory function that choroidal neovascularization becomes a very real risk? And that is where OCT and especially OCTA, and I did not put that into these slides, but that is where having that one baseline, that early, very solid workup can help you manage this patient appropriately and very accurately going forward. So in the case of Best disease, you can see on the left side there too, another fundus autofluorescence. You can see how from a normal, as it begins to stage over time, it's that vitelliform kind of that vitilla-disruptive matter that begins to form, and that's when you start to see some of those vision changes. And that's why having not only the fundus autofluorescence, but on that bottom right, when you start to see that OCT, that can be a little bit concerning, especially if you're worried about a patient who has risks for age-related macular degeneration. If you're worried about a patient that has risk for a diabetic macular edema or a proliferative retinal condition, is because when it starts to build up underneath, that's when you start to see the elevation. And then it's incredibly important to know, is this a risk for a neovascular change and development that would require anti-VEGF and steroidal therapy? Or is this a macular dystrophy where this is the vitelliform matter that is building up, but not causing the risk at the current time? But bottom line on a lot of these patients, you must monitor them closely. And there's a really nice American Academy of Ophthalmology guideline, and we'll talk about it at the end, is depending on what their presentation in, there's a rule of thumb is, do I see them in 3 months? Do I see them in 6 months? Or can I see this on a routine basis? And it's those checklists that have been something near and dear to my heart that I use in clinical primary care practice on an almost daily basis. So now here's one that becomes a little bit easier. So in the realm of macular dystrophies, we've talked about Stargardt's, we've talked about the pattern dystrophies, we've talked about Best's, vitelliform macular dystrophy, and X-linked retinal schisis, just by the very nature of its name and its diagnosis, tends to be a little bit easier diagnostically because it tends to be a male-dominated condition because it is X-linked. And because it is a retinal schisis, that is where your OCT is absolutely instrumental. So when you see that schisis change in the center, when you start to see that bubblegum split or the alligator teeth, depending on who taught you during residency, there is a schisis or a splitting of those retinal layers. And I think the thing from a X-linked retinal schisis macular dystrophy standpoint, there's a really unique phenomenon out there. So if you go into the diagnostics, this is something that I just happened to run across because I had never seen it before. I'd never even heard about it before, but it's that Mizuo-Nakamura phenomenon. Literally, when you expose the retina to very bright light, it actually changes its color appearance and then it comes back to normal. I wish I could tell you more about the exact physiology and chemical cascade that causes that, but it's a very unique phenomenon that tends to happen in X-linked retinal schisis. And on top of that, from any schisis, not necessarily just schisis, but cystoid macular edema, diabetic macular edema. It's something that I've liked to do in clinic, and it's in one of my previous slide presentations as well, is a topical pharmacologic option, a way to try to pull some of that fluid out or diminish some of that macular edema. If the cornea can support it, they don't have a corneal dystrophy or they don't have a pump mechanism that you think you would inhibit, using a topical CAI or using a topical dorzolamide or acetazolamide, if you can take some of the fluid out of the retina, you can actually reduce some of that schisis and you can actually give them a little bit better visual function back. It will not stop the process. It is not curative in any manner, but it's just something for an optometrist to keep in their pocket to help kind of minimize some of those anatomic changes and even kind of minimize some of those symptomatic changes that the patient might be experiencing. So a couple examples of that. X-linked retinal schisis, that one is almost pathognomonic. When you see that schisis, that splitting of the retinal change from a purely macular dystrophy standpoint, just going back one slide, this tends to be early presentation. This tends to be somewhere in their, 9, 10, early teens type of presentation. But when you do that fundus autofluorescence and you pair it with the spectral domain OCT, you can start to get, there's a very frank splitting of the layers, and that makes X-linked retinal schisis, comparatively speaking, a little bit easier diagnostically from a macular dystrophy standpoint. So here is one where I'll have a case presentation.
Chris,
Oh, go ahead.
Chris, before
Sir.
a question came in late about the plaquenil testing. As mentioned by one of our attendees, recently patients are telling me the rheumatologist is not asking for the additional testing. Should we do it anyway for baseline and annually if they're on the medicine? What are your thoughts there?
That's a great question. So I think it was a change in either 2017, 2018. There's actually a very nice clinical rubric. Off the top of my head, I don't want to speak incorrectly on it, but in general, I think I would still recommend doing that baseline because, again, during my residency, my attending was big on CYA. For the sake of the audience, it's cover your butt, meaning that the CYA practice was, these are the clinical guidelines that have been given to us. And even if the rheumatologist or another provider is not practicing in that mode, I like to follow established clinical guidelines. So if the individual that asks a question, and a great question, If you email one of us or email me directly, I believe it's 16 or 17. It's a very nice, strict when to monitor, what to test for, and what to look for. And especially from a visual field standpoint, there are differences on demographics. So if you have some of Asian descent versus Caucasian descent, you need to do different types of Humphrey visual field testing because the clinical presentation can be different. So to sum it up, I personally would still do the additional testing just from a CYA and just from the best interest of the patient.
Let me take out a step further. I work really closely to a right next, literally 2 miles down from my office, mile and a half, a 8-man woman rheumatology practice. They send me a ton of their Plaquenil, patients to follow. The mixed connective tissue diseases, the Wegener's, the rheumatoid arthritis, the Sjogren's, all the gamut of the rheumatological patient. And those guidelines, you're correct, Chris, 2016, 2017, where they basically said, oh, all you have to do is test them at the beginning. You can wait 5 years and don't have to worry about doing anything. I'm going to tell you that that's not what I would do, because there are people that are very thin, taking 200 milligrams twice a day. It's 400 milligrams usually daily that they're taking, 200 milligrams in the morning, 200 milligrams at night. And some people are obese. The medicine builds up. Some people are thin. It's too much for them in a sense based on their body weight, and because it's usually the 200 that they have to take twice a day. Summing this all up by saying I test them yearly. You are correct. The Asians, it's a little bit further out. So you need to do more of a 24-2, but if it's an Asian, because it's more of the pair E foveal area. If Caucasian or a Black person, I would do 10-2s and an OCT on an annual basis, just because everyone is metabolically different and everyone is a little bit overweight or underweight, and it can influence them. So that's an excellent question. I love evidence-based medicine, but I've proven it wrong multiple times and picked up Plaquenil toxicity before that 5-year mark at 2 and 3 and 4 years, just because the patients they were on other medications and they weren't as metabolically healthy. So I would do it on an annual basis.
Yeah, and I think that's a great point because every patient is going to be very different. So if they're on a number of different medications, that is going to absolutely affect their renal clearance rate. And as Greg astutely mentioned too, depending on their weight and their dosage, that can play a big role. So yes, I think that I would defer to Greg's expertise on that. I think annual workups, especially in the presence of any visual changes or any ophthalmologic changes, if you're seeing something that didn't just fall out of the sky, that needs to be explored. So I concur 100%.
The next question is going to roll in is, will they pay for it? And the answer is yes. You're going to pay for it. They're on a high-risk medication. You're making a clinical decision. Yes, they will cover it.
Very good.
Hey, Chris, another question rolled in. What role, if any, does AREDS2 have in management in patients with retinal dystrophies that affect the macula?
That's a great question. To be honest with you, the AREDS2, one of my favorite topics. I think Emily Chu published a number of different papers on that. The AREDS2 does not, at least in my experience, have a very strong role to play in a macular dystrophy. And the reason I say that is because the pathophysiology that underpins macular degeneration is a little bit different than what a macular dystrophy is. And specifically in AREDS2, the formulation and the clinical dosing is built on where they are from a drusen formation. So really AREDS2 has a lot more to do with whether there are drusen formation at an intermediate or greater level in an AMD patient. So it's possible that I am not as familiar as I should be, but from an AREDS2 standpoint, I haven't seen good guidance on necessarily if it would be beneficial in a macular dystrophy patient. But from my understanding in my clinical practice, the AREDS2 and the data that came out of that is very specific on the drusen formation in an intermediate atrophic. And from a macular dystrophy, because the pathophysiology, because the metabolic pathways are slightly different, I don't know if AREDS2 would be necessarily a good fit, if you will, from a macular dystrophy management.
Chris, I agree with you. In fact, the analog to that would be those patients who have no AMD, no drusen, who are using it because they think it's going to prevent it or it's good for them. We don't know.
Right. Yeah, absolutely. And that's a unique thing too, is in the AREDS 2, if you dig real deep into the data, in fact, unless there was intermediate or severe AMD changes, the individuals that had high risk but no maculopathy or even mild maculopathy, in fact, demonstrated no significant value and really created expensive urine by using the AREDS 2 formulation. So it is a very specific formulation. And I think Joe and Greg and I have chatted at numerous conferences on this one, but that was part of my graduate work, was on the AREDS and macular pigment and so forth. So if anyone has any questions on that, I've got some slides. I'd be more than happy to share the exact clinical guidance that came out of the AREDS 2. More than happy to talk about the exact patient population you should be utilizing AREDS 2 in. Yes, sir.
And I agree with the AREDS too. It's probably too high of a dosage. It's too specific. But in some of the patients, that I'm into functional medicine, is that maybe a low dose or more comprehensive would not be, maybe not treatable, but maybe, would help overall just kind of calm down the oxidative stress in the body and in the retina. But I agree that the AREDS 2 is just too high, too specific, and not the appropriate. But a more comprehensive antioxidant approach might be the way to go.
Yeah, no, I can echo that. I think Greg's exactly right, because then if we start looking at things outside of the standard AREDS to the high dose antioxidants, I think there are a number of functional medicine approaches, and that would go a little off scope here, but I'm in Greg's court on this one. I think that's absolutely appropriate to look at that. And that's a discussion I always love to have, because I think that is something from a primary care optometry standpoint. I think that's some unexplored territory. And the oxidative stress, the microvascular insults, the chronic singlet oxygen and free radical damage, that metabolic pressure causes some of the progression that we see in a number of different retinopathies. So I agree entirely with that as well. Absolutely. So to make sure, in the interest of time, I think I'm looking at 55 minutes on the dot right now. Progressive cone dystrophies. So we moved outside of the X-linked retinal schisis. So this one can also be a little bit unique in its presentation. I'll have another case presentation in a moment on this one, but you can see its prevalence tends to be a little bit lower. So this is less common than the best retinopathy. This is less common than Stargardt's. This is less common than pattern dystrophies, but this one does tend to present with vision loss. So this is also one of your cues in a very comprehensive eye exam. When that patient comes in and they have significant vision loss and they are essentially in their 30s or 40s, not quite into the age-related macular degeneration, they don't have any underlying, say, systemic presenting retinopathies, metabolic disease, hypertension, hypertensive retinopathy, diabetic retinopathy. But these are the ones where its presentation, especially on fundus autofluorescence, and I'll show an example of that. That is where the fundus autofluorescence paired with your spectral domain OCT can be very, very important. Just in the interest of time, I'll jump right over there. That's what you want to start looking for, is because you're going to, we talked about plaquenil toxicity pretty extensively. When you start to have some loss of those outer retinal layers, and you start to have a loss of those that ellipsoid zone outside in that outer retinal layer, it's not only that you start to get some thinning and some loss of that Henle fiber layer, but you start to get this ring on the fundus autofluorescence. And that can actually be a really nice cue that, in accompaniment with progressive vision loss or fairly moderate vision loss on initial presentation, with thinning of the outer retinal layers and that ring, that bright hyper autofluorescent ring right around the fovea, that's where you start to look at progressive cone dystrophy. And in a moment here, we'll get to the table, and that I think is the thing I've found the most use for in primary care practice, is checking the boxes, is almost like a diagnosis of exclusion. is their vision poor enough to consider this? Is their vision too good to consider this? And so on and so forth. And so that's why I think the progressive cone dystrophy, especially if you're starting to look at a pattern dystrophy, that's where the difference is. Pattern dystrophies don't tend to have the significant vision loss. They don't tend to have the color vision abnormalities, but you get into progressive cone dystrophies. Now you've got some significant changes of everything you would associate with cone function, high resolution visual acuity, high discerning color vision. That's where you can start to make some of those decisions without any imaging, and then use your imaging at the end to seal the deal and really make a concrete differential, if you will. And then this is the one where now we're starting to move into kind of springboarding off the AREDS 2 topic. If you get into the ADRDs and the Doyne honeycomb, these are interesting because I know even when I was a kid many years ago, these were always discussed in our lectures as kind of distinct clinical entities. But as I started really digging into some of this, there's so much crossover that in most cases, these are considered almost concurrent conditions. And when you start to look at the genetic risk, I think that is where the authors, and I'm happy to share any of my papers with you guys, that is where some of the papers, the genetic risk has that shared allele. So when you get into Doyne honeycomb and ADRDs, they have that same genetic risk factor, although the clinical presentations can be a little bit different. But this is the one where, going back to the AREDS and the AMD, this is the one where it is an AMD mimic, but critically important for you is to look at where the signs started, because someone in their 30s and 40s, that would be relatively unusual to have significant drusen changes related to age-related macular degeneration in their 30s and 40s. Even AREDS 2, a lot of their data started in a patient population 55 and older. So sometimes what happens is we utilize studies that were very specific in their patient selection and their population, but we need to be cognizant of what that study is telling us because it's very specific to their controlled population. So bottom line, when you start to see all of these drusen in a relatively younger individual, they have a relatively normal best corrected visual acuity, their color vision tends to be relatively normal, and you're thinking AMD mimic, that is where these can look also very, very drastic. And clearly I chose these pictures because they're Kansky type of pictures, right? This is not necessarily what you're going to always see in an autosomal dominant drusen, but these are the type of things where their vision probably is too good for what you're seeing, meaning the retina looks drastic. Like something looks very, very wrong, but their vision doesn't seem to be as poor as what you would anticipate. So going back here, this is where I think it becomes very important to not only look for the spectral domain OCT, but the fundus autofluorescence, get that good baseline. And now you're looking for progression, because the big risk too in the ADRDs is the development of a neovascularization because of the progression and the loss of that metabolic substrate that we talked about earlier. But I think the interesting thing here is it's an AMD mimic, and when you see these diagnoses, they're in fact referring to a single clinical entity. And in the interest of time, I'll keep on moving. So you can see here is your ADRDs, and then you move over to the Doyne honeycomb. You get that drusen formation, so it's just a nice picture on the bottom with the arrows pointing to the drusen formation, but that's where your clinical acumen comes in. If this is a patient in their 30s, 40s, pretty unusual to have an AMD on this one, but that's why this just needs to be in your clinical compendium, if we will, as a potential differential in a younger patient that's having drusen formation. And I know, and again, as I illustrated earlier, it's very information dense. These are your slides. I can send them out. I'm happy to send out all my research on there, but I just want to make sure that I'm moving along for you guys because we haven't even gotten to the white dot syndromes, and I want to make sure I get to the very end for you guys. So now we get into Sorsby's fundus dystrophy. Now these are the ones where these are the zebras. So everything we've talked to up to this point, The prevalence can be there. There's a certain probability that this patient may walk off the street into your clinical lane. But now we're going to get into the North Carolina macular dystrophy, the Sorsby fundus dystrophies. These are the true zebras. These are the ones that you may encounter, but you may never encounter these clinically. And so I think the important part here is if you start to use and look on the left side with the genetic risk we talked about, the diagnostic risks we talked about, diagnostically, this can mimic a lot of different things. And if you look at that OCT on the bottom, there's drusen formation in there. It becomes a very, very difficult to know what could this be, and does this need a refer to retina? Is this something I can manage? Is this something that has been present for a long time? So that I think is where the Sorsby, and as we get to the North Carolina macular dystrophy, these become tricky because these are absolutely almost a diagnosis of exclusion. And when you look at the Sorsby dystrophy, it's not as frank as you might think. So when you start looking at moderate BCVA loss, when you start looking at the loss of color vision and those night vision loss and nyctalopia changes, when you start looking at the retina, box E, essentially the changes there at the RPE, it's a little bit of a red herring. That's a separate entity. But when you look at the retina, it's not as drastic as you might see. You can see some early kind of parafoveal drusen changes in A and B. You get down into E and even F, and F is a fluorescein angiography. It's not as drastic as you might think. So in my clinical experience, and Joe and Greg may absolutely differ on this one, Sorsby's becomes kind of a diagnosis of exclusion. I'm looking at a probability standpoint. It's much more likely that it's going to be one of the first 5 and a little less likely that it's Sorsby's. But here's where the genetic testing is probably the true discriminator on what this is, because again, the management is very similar in a lot of these macular dystrophies. At the current time, there's really not an effective way to arrest, or there's not a curative approach to many of these macular dystrophies. It's a monitor against a significant neovascular change that can cause profound vision loss.
Chris, you mentioned genetic testing, and a question rolled in, and I think it is more to do with AMD and off topic, and we're not going to go too deep into it. But when you mention genetic testing, how do people avail themselves of this?
That's a great question. So within the genetic testing, specifically for the macular dystrophies, I'll start there. I'll actually have a slide at the very end, and there is literally a giant database out there, and you can go straight to this website and you can choose the panel that you want. So this is one of those where the tool is out there. I think it's a very, very good tool. You can absolutely involve yourself in genetic testing, but just a word of caution, and this is maybe just me being a little bit more conservative in my clinical practice. If you're going to venture into genetic testing, you have to have an off-ramp. You have to know what are you going to do with that information when it comes back. And when you are ordering a genetic test or an allele panel, and we'll talk about those in a moment, what are you hoping to do? Is it just to differentially diagnose and say, oh, this is a Sorsby's versus, say, a pattern dystrophy? Or is this for a true management decision that you're going to do? And what can also happen is, especially if you're just using it for confirmation of a diagnosis, if there's not a viable treatment, and this is maybe just speaking as a parent, I've got twins at home, what am I going to do with that information? If it's a progressive condition that has no known treatment, yes, there is certain comfort that can be gained and gleaned from doing the genetic testing, but what am I going to do with the information that says you now have a genetic risk allele that may result in profound vision loss, but there's not a darn thing I can do about it? Know what you're going to answer to the patient if you choose to do that. And on the AMD side, I have a different slide deck. And again, in the interest of time, happy to send that out. There used to be an Arctic DX. There's very specific complement factor H tests out there. There's very specific ARMS. So the age-related macular degeneration and maculopathy sensitivity. So CF, complement factor H, and ARMS. Those are 2 big ones in AMD, and I can send a slide out on that. That's something that I don't do a lot, but it is in our arsenal.
And a real quick question, how do you differentiate nyctalopia from macular changes from myopic nyctalopia?
That's a great question. A lot of times, if I'm thinking that it's going to be a myopically driven nyctalopia, I'm going to look obviously at the refractive error on that one. But a lot of it too is I will ask leading questions to the patient. So some people will present and say, I have night blindness. And what it is their pupils are large, their prescription's not ideal, and they have a lot of higher order aberrations. And what they're reporting as night blindness is simply they're just not seeing well at very night. But what I'll try to elucidate is when you walk into a movie theater, if you were to turn the lights off, how long does it take for you to be comfortable to take a step into that room? Meaning, if you walk into a movie theater and the lights are down, if you cannot find your seat, if you have to hold on to things to walk down the aisle, or you crawl into bed at night, you can't flip the lights off. You got to clap them off, because if you do turn the lights off, you can't find your bed. That's where that true nyctalopia can play a role. And from a commercial diagnostic testing, the dark adaptation. So there is an Adapt DX commercial device out there. That's a really nice way to actually quantify some of that nyctalopia change.
Excellent.
Thanks, sir. So North Carolina macular dystrophies. So this is another one, zebra. You can see the prevalence. These prevalence numbers are even more difficult to truly ascertain with a great deal of accuracy, only because they are so very rare. And it's really interesting that the North Carolina macular dystrophy, we call it that, and we've given it that nomenclature, but it's likely a misnomer, because this exact presentation with the same genetic risk alleles have presented outside of the state of North Carolina. But for our purposes, we'll call it North Carolina macular dystrophy. But you can see, again, relatively normal BCVA. When you're looking at on the top left, that is what the color fundus photo looks like. You move to the right, that is essentially what the fundus autofluorescence is going to look like. But that's why it's a nice cue to look at that, because when you look at those two, that's the corresponding OCT below it. And yes, you have some RPE changes, just very, very kind of subfoveal, and you have some just small changes to that ellipsoid zone, but it's not as frank as some of those other macular dystrophies we've seen. But this is another one where it can be an AMD mimic, but that's where it comes back to it's a congenital. So if this is a patient who's 10, 15, 20 years old who has these kind of AMD looking signs, that should be the first kind of differential clue to say, are we sure that this is truly a macular degeneration, or is this something that we need to look at as a macular dystrophy? And that's where the slides that I'll show in a moment, using the clinical practice guideline and using the tabular of probability, age of presentation, demographics, can help you make that that differentiation a little bit earlier. And again, very amazing pictures, great slides, but again, in the interest of time, because of the rarity on this one, this is one where it is absolutely a diagnosis of exclusion. You want to make sure that it's not a progressive cone dystrophy, a pattern dystrophy, a Stargardt's. You want to make sure that there's not something else before you would move to a North Carolina as a differential. So poll question 3, I've been talking so long, I want to make sure that I get the crowd back into it. As we move into this, I'll read it out. What items were discussed earlier as an effective clinical adjunct to the diagnosis of macular dystrophies?
The polling question is open and answers are starting to roll in. Any other questions, Joe?
No, we're good.
Well, I think for the purpose of time, I think the trend has been set. And so I'm just going to display the answer so you can kind of keep on moving here. And the answer is we have 8% going with clinical practice guideline, but 92% going with both A and B.
Excellent, excellent. And so it's a little bit of an unfair question only because we haven't gotten to those, but that is where we're headed right now. So that is the purpose of putting that polling question there. So what I've done and what I've used in my clinical practice is this is the table right here. At the very end, I've got a whole bunch of clinical practice guidelines. I'll send them to you directly. But here's what I will use in a macular dystrophy rule out. It is not the panacea. It's not a perfect solution, but I think it helps just really differentiate that if I have a patient early, what is my quick and easy primary care? I've got 20 patients on the books today. I need to make a decision. Do I warrant extra testing? Is this a referral immediately? Or is this a return to clinic? Or is this a stable finding that has been well documented that is showing no visual progression? So let's see this table in action. So here we have a 56-year-old white female, best corrected visual acuity 2020 monocular OD/OS. You can see the HRR, so the color vision testing passed the table 5 through 10. And so that's a kind of an interesting one. Again, I won't harp on it too much, but we'll get at the very end. The Hardy-Rand-Rittler, it tests right on the color line confusion. So from a macular dystrophy, I find the HRR the best. And very simple patient history. So talked about family history, talked about medical history, nothing of significance to present. So as we look, and that was perfect teeing up about 15 to 20 minutes ago, Plaquenil. There is something that if I looked at that and I heard she has a rheumatologic, she has an autoimmune, she has a mixed connective disease condition, and she's on Plaquenil, that would make me very nervous looking at that right there. That's why I'm like, is that a bullseye maculopathy? And is that truly the diminution of those outer retinal layers? Because that is a little bit what a flying saucer sign can look like. But because there was no family history of that, there was no medical history of that, and she's not using any medications, that gives me my step 1, step 2, and step 3. So step 1, as we talked about at the very beginning, there was no family ocular history presented in the 6th decade of life. Clinical findings, everything in green, fairly normal. There's your SD-OCT. When I saw this patient, I did not have fundus autofluorescence, dark adaptation, or full field ERG, but probability-wise, you can see the ones I lined through. She's a female without foveal schisis, so that's an easy one to describe. She's progressive cone dystrophy, but she has too good a vision. I wouldn't think a progressive cone dystrophy should have 20/20 vision. I didn't see any drusen pattern in there, so that helps me with the Doyne's and the autosomal dominant drusen. And Sorsby's, again, 20/20 with no drusen pattern. And I did not put the North Carolina macular dystrophy because that's a 1 in a million chance. That's literally a Dumb and Dumber line that it's 1 in a million. The chances of that being in North Carolina, very unlikely. So there, using our table, you can see pattern dystrophy is the one that is most likely to this because she has normal BCVA, has some macular deposits, has a hyperreflective RPE, but she doesn't fit neatly into the Stargardts or the best because her vision is too good. The time at which she presented doesn't make sense to the others. So this is not a locked, definite diagnosis, but it's a very good early differential to help you manage this patient in an expeditious way. So moving on here, and again, in the interest of time, I will say this is definitely a red herring. I threw it out there just because the eyes do not live in isolation from the rest of the body. So this is a patient, lots going on. This was not a patient that we didn't know what was happening, but you can see that this is a patient that already had some systemic condition concerns. There was already a history of pyridostigmine. She'd been using this for a while. It looked like there might have even been a chronic progressive external ophthalmoplegia. The one thing that when we had looked at this patient, you're really trying to rule out like a myasthenia gravis, right? So when you're looking at the Cogan lid twitch and the stable fatigue, if you fatigue out the muscles, asking the patient, again, you look up, look down, move it around a lot. Okay, your eyes aren't going to move like that, but move your eyes in a significant pattern, really fatigue out those muscles. If you get a significant ptosis or you get significant changes after about 30 to 45 seconds of that, ice pack tests are a nice one, but it's a stable position after fatigue. So from a myasthenia standpoint, doesn't necessarily make me think that that is where we're going. But when you see color visual is relatively normal, does have some macular pigmentary changes, And then the picture on the bottom right, that's an infrared image. So that one's a little bit different than the fundus autofluorescence. But you can see that top right picture, that looks like a maculopathy. So she has a maculopathy, but has all these other things going on. Again, in the interest of time, I'll go quickly through here. This one is absolutely a red herring. I put it out there because it doesn't fit neatly into these boxes, because in general, macular dystrophies don't always associate with a systemic or a syndromic condition. So when you're looking, it's a primary care eye exam. So you're looking at the eyes because they're there for an eye exam. But when you use our checklist, you can't forget that if there are other systemic conditions, if there are other things that are presenting, that the patient has a history of concern over myasthenia. She had used periodostigmine. There was some unique kind of just ophthalmic, chronic, progressive external ophthalmoplegia. There's other things that are very unique. And so this one I pulled out as a review syndrome because when you're an optometrist, don't lose sight of just looking at the eyes, and no pun intended. Really take a good case history, ask some questions, and really get a good overall feel for what that patient is presenting for in your chair, because there may be other things that are also related. And for a number of these syndromic conditions, there can be cardiac risks, there can be renal risks, there can be hepatic risks. So we are part of that medical management team. And so it takes a village. So critically important that just because it's a maculopathy, is it related to anything else in their systemic history or that overall patient presentation? And this will be my last one before we move to the white dots. But this is another one too. Patient, this was one of mine a few years back already now, but 20-year-old black male, best corrected visual acuity. I like to think I'm okay at refraction. I refracted this kid for 10 minutes, which doesn't sound like a long time, but if you practice for a while, a 10-minute refraction is a heck of a refraction. At the time, this was a member that I'd seen in Air Force. So I only had the cone contrast test, very non-specific. So if you've ever seen the cone contrast test, it was not very repeatable. It had kind of almost not flatline, but I had diminution across all three cone channels. And this one, he had a little bit of confrontational field. He could get there, but you had to move your fingers in, and you had to be very, very exacting. In someone who typically does not have a confrontational field deficit, they pop it off right away. If they're struggling and they have a lot of difficulty, especially when you come back to those same primary positions of the temporal, superior, nasal, inferior, if they're having trouble, that warrants addition testing because a normal confrontational field should be quick and effortless. So the pictures here, this is the first thing. So looking at that, right off the bat, I'm thinking CCAD, right? That's a central areolar choroidal dystrophy because it's diminution, but the patient said, I'd never been dilated before. So we dilated, and that's what the eyeball looked like. Now, right off the bat, I'm like, well, this is weird. So I don't know exactly what's going on. This is a patient that's being worked up. We're trying to qualify him for a position. We're having a lot of trouble just getting you qualified, but now I've got a second issue because this might be a disqualifying condition for service entirely. So you can see with all of that retinal whitening, you have a significant change right there. Not only the fovea, but it's almost so large, it's encapsulating the entire macula. So this is my color fundus photo, but here is where the rubber really hits the road, is because when we talk about macular dystrophies, this is a 20-year-old male. You can see that there is kind of just like a generalized change, like a thinning, even if it's non-specific. If you follow those hyperreflective layers, which a true normal OCT should have, you can see that it actually bends inward. It's actually thinning out there in that outer retinal layer. And then here, that is really where the driver comes from. There's that bright, hyperfluorescent fundus autofluorescence that kind of rings the fovea. So having that information right there, I don't have any real good history on this patient at all. I have 15 minutes to figure it out. So here's kind of where we're at. The clinical findings, I had put 20/40 on the other one, 20/40, 20/50. It was really rough to get this kid down there. Abnormal color vision, you can see all those changes. Probability wise, unlikely. Could be a Stargardt's. There is some reports in the literature that there can be like a almost like an RP sign pigmento. You can have some Stargardt changes that don't necessarily present with that flecking that you would expect. But in this patient's particular case, everything else fit, and it was really the visual field restriction. That was the thing where I was most interested. Is this truly a cone dystrophy, or are we now moving into a cone rod or a rod cone dystrophy? So this one, I did make a retinal referral, but my differential kind of based on that right there, I'm thinking cone dystrophy. That's a progressive cone dystrophy just based on the age of presentation, what I saw on OCT, and then this hyperfluorescent foveal ring. That is what drove me to the progressive cone dystrophy as a differential. And so now we'll move into it. I have about 27 minutes left, so I'll keep us moving. So here's where we talk about macular dystrophies. Patient presents, and now we're already keyed up. It's the bias of recency. We talked macular dystrophy for almost an hour and a half right now. So now we're thinking, well, if it's in the macula and it's a patient in their essentially third decade of life, must be a macular dystrophy. But here's where you can get a little bit, where it gets very, very tricky in the white dot syndromes, because once you get into the white dot syndromes, these tend to present a lot like one another. These get very, very difficult. And I will say in a primary care setting, these require a little bit of additional digging, using UpToDate. When you step out of the patient's room, these are the things that I've built another table that what I like to use in primary care, because these can be very tricky and very complex. And almost all of them are going to require an in-depth patient history. You need to know what medications, what conditions are being managed, and you're going to need some additional ancillary testing on these. OCT, fundus autofluorescence, but this is where having some dark optometry and having some additional testing on ERGs can be very, very valuable. So some of the assumptions, as we talked about for macular dystrophies, because prevalence is really a function of incidence and duration, it becomes very tough to know what is the true prevalence rate of a white dot syndrome. And because white dot syndromes in some cases can be self-limiting, we may vastly underrate and underestimate some of these because the patient may have had some visual difficulties, but they resolved on their own. And so we never captured that data. So it's tough to know what the actual prevalence rate is on these. But I will say, if you're thinking white dot syndrome, 25, a quarter of them are going to have a concurrent autoimmune condition. I have a separate presentation. I think I'll get a chance to work with Joe and Greg here in the future and talk about autoimmune. But the autoimmune conditions, that's really where optometry can show its ilk, is because those autoimmune conditions can have very specific presentations in the eye, and this table should help show some information on that. I thought it was also interesting doing some of the data research prior to some of the COVID data and post some of the COVID data. The numbers are changing. So there is an autoimmune, there is a long-term cascade that entire complement pathway is changing, and it's that complement pathway that is driving some of these white dot syndromes. And we're going to talk a lot about the human leukocyte antigens, HLA, and essentially the herpes viruses. So I know Greg has done a really good presentation on clinical HSV in the past, but Epstein-Barr, this Epstein-Barr virus, SLE is linked to Epstein-Barr, MS is linked to Epstein-Barr. So having an idea, have you had mononucleosis? Do you have a history of herpes virus infections? These can be some of the clinical cues, and that is in my clinical practice guidelines that I'll share with everyone. But asking those questions can give you that one extra clue to how much further do I need to dig to identify that differential diagnosis for further testing or best patient management. So again, going quickly through here because I want to get to the very end, because that's where we get into really like, how do I manage a patient? These are the kind of tricky ones. So this is MUDES. When you're looking at MUDES, this is almost the easiest one to manage. So I think somewhere in all of our clinical experience, everyone has seen a MUDES at some point. This one I think is a little bit unique because it tends to be unilateral. So as we talk about some of these white dot syndromes, they can be unilateral or bilateral, but in general, not always, but in general, this tends to have a viral etiology. There tends to be a viral anathema on this, and it tends to be unilateral when you're looking at these. And so The good thing about MUDs, it tends to have a spontaneous visual resolution, but that doesn't mean they're out of the woods, so to speak. There is still a reason that this popped up. It tends to be the viral triggered it, but that's because there's an autoimmune condition underlying all of this. So when you see a lot of these white dot syndromes, you got to think that there's an autoimmune condition that's driving this to begin with. And just in the presentation on meat, they tend to be kind of these kind of discrete dots that kind of cover that mid periphery. And a way to differentiate somewhat from a macular dystrophy is the macula, the fovea can be affected, but you tend to see these white dots forming in kind of that macular region and that kind of mid peripheral region. And you can also start to see that it's a wreath pattern. It tends to ring around that mid peripheral. So looking a little bit at the AMPI, I know I pronounced that wrong, but that's how I memorized it in school. So this one you can start to see too, HLA-B7, HLA-DR2. So these are, again, those human leukocyte antigens. Every time you're thinking white dot syndrome, you're seeing some weird kind of white, yellowish, discrete changes in the back of the eye. Autoimmune has to be ruled out. And if there's one thing that if I can offer or everyone takes home, autoimmune tends to be the driver in many of these white dot syndromes. Kind of going down, you can see the systemic associations, viral prodromes. This is an individual that either has been sick in the recent past or is currently under care for some type of non-specific autoimmune or viral condition. The prognosis on these, again, tends to also have good resolution, but this one is a little bit different than the MUDs we talked about because this one tends to be more bilateral. So when I'm seeing these changes in both eyes, that makes me lean away from a MUDs and more into the acute posterior, the epitheliopathy that presents with the AMPI. You can see that you have that kind of disorganization of the outer retinal layers, and you start to get that photoreceptor loss. So that's why I had tied this presentation in with the macular dystrophies and the white dot syndromes, because you tend to see some of these outer retinal layer changes. And again, as Greg had mentioned earlier, when you're seeing these outer retinal changes, it's because the RPE, there is some type of dysfunction, whether it be metabolic, whether it be high oxidative stress, whether it be a chronic kind of microvascular insult, you tend to see disruption and change at those outer retinal layers. Multifocal choroiditis, this is another one too. Females, unfortunately, it shouldn't come as a surprise necessarily because in general, females tend to have a higher prevalence, a more frequent occurrence of an autoimmune condition. So it stands to reason that in general, a female patient would have a higher risk of developing a white dot syndrome. So I think the multifocal choroiditis, this one, if there's a discriminator out there, it's the overlying vitritis. So when you have a hazy view getting back there, you're just having a tough time. Is it out of focus? Is my lens dirty? Why can I not get a good view? In my clinical experience, I like to follow up with a SD-OCT. And if you change the zero delay line, you can actually image a little bit in front of that vitreoretinal interface. If you're seeing discrete white things flowing, like showing up in the vitreous, that shouldn't be there. The vitreous should be optically empty. So it's a nice little discriminator that if I'm imaging the back of the eye from an OCT standpoint, and I'm seeing a bunch of floaties, if you will, in the vitreous, especially near the retina, I'm thinking vitritis. I'm ruling out vitritis right off the bat. And so you can see again, that's where the hypofluorescent, it's really nice to also follow up your OCT to not only look for changes at the RPE and outer retinal layers, but also look for any type of vitritis in the back of the eye. But following that up with a fundus autofluorescence makes a really nice kind of concurrent. Now I'm seeing that hyperfluorescent change means there's metabolic activity. There is something going on in those places where I wouldn't expect bright hyper autofluorescence to show. Birdshot chorioretinopathy, this one is almost not exclusively, but if you are thinking, if your patient has a condition with a link to an HLA-A29, if they have a risk of having an autoimmune condition, if they have had a workup, if they have had a true immunology or rheumatology workup, HLA 29, A29, that is birdshot chorioretinopathy. It's almost inextricably linked in the literature on this one. And you can see that systemic associations, that's how strong that link is. So if you have a patient with a history of birdshot chorioretinopathy or you suspect that, that drives a rheum or an immunology workup because that is a very strong link. And again, vitritis. You're always looking for that overlying vitritis. And so when these patients present, it's not just at the retina. Pull back on the on your slit lamp, move the lens slightly. And if you are getting haze, if you are getting opacities through that vitreous, that absolutely is an indicator on what type of white dot syndrome you might be dealing with. And you can see the, again, photoreceptor and the ellipsoid zone. You can see that disruption at the back of the eye. And what you start to see too is visual field loss. I know that it seems easy, and I know all of us have been clinicians for a number of years. Don't speed through your confrontational fields. And if you have technicians doing it, if you have interns, residents doing it, force them to be very repeatable and force them to do a good confrontational field because it's an early, completely free indicator to you that is there a rationale to do additional testing? Is there a differential that you can already rule out earlier? Serpiginous chorioretinopathy, and I know we're flying through these, and I do want to emphasize these are all for you. I have a table coming up in a moment, but you can see, again, the serpiginous chorioretinopathy, the one that becomes a little bit unique here is it tends to be a little bit more common in males than in females. And in the table I'll show in a few slides, it will actually kind of outline why these things tend to happen and what you can use as a checklist. So as you go down through the white dot syndromes, this is the one where the scarring begins to move out from that optic nerve. And this is where if you see some chronic scarring, you start to see some risk of chorial neovascular membrane development. That is where the OCT becomes absolutely critical. But if we go all the way back to BEST, when we talked about, this is the part where your clinical acumen becomes critically important because when you look at that CNVM, look for breaks in the RPE. Look for, because these are choroidal neovascular, and our anatomy, if it's choroidal neovascular, look for breaks in that RPE, because if you're seeing breakthroughs in the RPE, if you're seeing changes or non-congruity or incongruity in the RPE, you're risking, or you're seeing some of the early changes that are leading to a high risk of a neovascular or a choroidal change. And so Azure, I know we're flying through these, but this is another one, very, very complicated. I don't think I've seen an Azure present to me for just that. I've inherited some of these. I've had some consultations for management on other things on these, but these are the ones where you can see the prevalence on these very, very low. And interestingly, Azure was one of those conditions, much like outer retinal tubulation, disorganization of the retinal inner layers. These are things that with the advent of high resolution imaging, the spectral domain, some of the new swept source OCTs, because our resolution is so much better, these are now diagnostic conditions that 30 years ago we didn't know because we couldn't see them. So with our imaging changes, as that continues to progress, we may see even better differentiation, even better clarification on what these white dot syndromes are really presenting at and some of the early management techniques. And so there is where that fundus autofluorescence is. You get that inner, you get the rim, and then it's normal outside of that. So as we mentioned for the macular dystrophy is much the same when you're dealing with a white dot syndrome. The OCT paired with the fundus autofluorescence, those two are critical pieces in your diagnostic workup. And then PIC, this is another one too. Strong HLA workup. And I know that these get very, very complicated because your case history, the very first thing you do, the most important thing you do in all of your cases is that asking the questions correctly. Have you had a systemic condition? What medications on? When was your last medical exam? Have you had labs drawn lately? Do you have a follow-up? And I know that these are, they probably sound routine and somewhat mundane, but your case history does not stop throughout the eye exam. As you're doing your exam, you're finding other clues and other Encyclopedia Brown type of changes. This is where that clinical case history must continue throughout the entire exam. And lack of vitritis. So this is the other cue too. If you see vitritis, you're not thinking PIC. You're not thinking the punctate intracorneal retinopathy, because this tends to be no vitritis, and the old lesions can look like multifocal choroiditis, but therein lies the conundrum. Is this a resolved multifocal, or is this a new presentation of punctate? And that's where the table here in a moment should really help, I think, show that up. And here's the table. So all of those slides with all of that information, this is what I like to use clinically, because if I suspect a white dot syndrome, I put this on the table and I look at it closely. This is what really helps me walk through this. And if you want, as we talked about, it's that HLA. There's an autoimmune condition, or there's a herpes virus. So the herpes viridae, there's about 100 or so that affect human. There's about 100 or so viruses out there, and about 8 can affect humans. And so it becomes critical to know, have they had chronic herpes outbreak? Have they had Epstein-Barr, a mononucleosis? Knowing some of this information can help drive you towards using this appropriately. And we have about 12 minutes left. So going through these case presentations, this was a patient of mine about 12 months ago, 27-year-old black female, kind of a round shimmering circle is the reason the patient came in. But as I'm looking at this patient, it's kind of unique because it's not just the eye. Before we even got into the eye exam, it drove me to ask other questions like, hey, have you, are you under the care of dermatology? She's like, oh no, these like little milia things, they showed up kind of recently. Like, have you been in to see the doctors? Like, I have a follow-up, here in a couple of weeks. So asking some of those questions, and there, when we start getting the medical history, eczema, and it sounds kind of funny, but eczema, psoriasis, there's an autoimmune component right there. So when I'm hearing that this is a dermatologic autoimmune condition, it's still an autoimmune condition that has a systemic impact. So when I find a patient, or when I have a patient tell me they have an autoimmune condition, there's a concern that they're being worked up for an autoimmune condition, that's already going to drive my decision going forward. So just like we did for the macular dystrophies, we're going to look closely at using that same checklist. As I mentioned, I'm Air Force. Pilots with 10,000 hours still use a checklist, because a checklist is critical. The checklist saves you from overlooking something simple. So using that step 1 checklist, family ocular history, age of patient. So right there, I've level set. So if I go back to my table here in a moment, that's where I'm starting. What is the family ocular history, and what is the demographic of that patient? If I go through the clinical findings, you can kind of see unilateral presentation of the soft white punctate. So once I see that, it's not insidious, it's not chronic. She just presented with that shimmering disc, had no reported history of anything retinal up to this point. So when I hear that, that makes my probability list a little bit easier. So when I go back up here, yep, I could absolutely consider that it might be acute posterior placoid pigmentary epitheliopathy, but because it tends to be unilateral, it's not saying that it couldn't be, but it's more likely that it would be a MUDES as opposed to an ATME. So that, I think, is how this chart, how this table can be beneficial in management. So I have about 9 minutes, keeping it moving. So this one, another case presentation. 2, 4
2 minutes.
2 minutes. All right. So let me go through this. I apologize. Let me get through here, because I think the most important part that I want to give to you guys, I know I had a couple poll questions left. As we talked about through this point, clinical modalities discuss what is the most critical to the diagnosis and management of a white dot syndrome.
I'll let you just answer it to save the time.
It is going to be D, all of the above. Much like if it's long, it can't be wrong. If it tends to be all of the above, it kind of makes sense. So going quickly, these are things I want to share. I've only got a few minutes. Again, I hate rushing for you guys. We had some great questions early, but technology is moving towards the direction that essentially augmented reality, some of these new AI devices coming out there, patients are going to use this. They're going to use this, and they're going to cross-check you, and they're going to use these devices. And this is a software. This is an application on your phone. This is going to drive them in. If you guys have any interest, sometimes it's tough to invest in a lot of this activity. These are the CAD files. If you have a 3D extrusion printer, you can print this right here. I give these out as gifts when I lecture at other locations. But if you guys want, I can send the CAD files there. This is another CAD file. It's not a perfect replacement for an anterior seg camera, but these are yours for free. This is open source. If you send me an email, I can send these CAD files. You can print out that exact holder that you see right there. And then takeaways. Here is, that question came up earlier. Here's the genetic panels, retinopathy and optic atrophy versus a comprehensive eye disorders. You can see that all of the allele risks that we talked about, that is where they can be found. And then excerpts here is that avoid testing asymptomatic patients. This is the one is if you're going to test, what are you going to do with that information? You have to have a plan. You have to have an off-ramp. And if you suspect, and I'll try to wrap it up here because we're going to go too long. As these slides are in there, I've got the peer-reviewed documents on why you would want to consider using these. But this macular dystrophy, white dot syndromes, this is where your money is made. This is what you do. Ask those questions in green, use the steps, and then it will step you through to what you want to do next. And in the interest of time, I do not want to impede on anyone else. I know it's very, very fast. I will get to the very end so you have my contact information. But quite literally, this is how I stay current. If you guys want to take screenshots of this, Cochrane Library, it's free, has a bunch of nerds that do giant meta-analyses, AAO preferred practice patterns, Hippocrates, up to date. These are things that I have on my iPad and I'm looking here. That's what I do every single day. And here are my handouts. Everything on the right, I have clinical practice guidelines for every single one of those derived from peer-reviewed literature. So if there is anything the table you would like, the clinical practice guideline, those are all for you. And this is what we do. And this is what I wanted to get to. Questions, anything. I love talking about this. For me, it's 2 a.m, but I'm highly animated. If there's anything that you guys need from me, I love working with Joe and Greg, but I want to give your time back. Thank you for your attention tonight. I really do appreciate it. Reach out to me directly. I love this stuff, and I'll be happy to answer any questions you might have.
Well, Chris, there are no new questions in there. Somebody thank you for including the white dot syndrome. Very informative. And I have to agree. I think we may need to offer a bit of apology to our attendees who are vegetarian and vegan because you have so much meat in your presentation.
That's on me.
So with that said, if you look at your screen right where it says survey right here, there's a little red dot that has appeared. You can start that survey. Please do that because again, we need it for the regulatory bodies, or you can do it at 9:30 Eastern when that comes via email, but you can do it right here, right now. It's a short survey. And Joe mentioned there's no other questions. And Chris, I always consider myself a pretty bright guy until I hang out with you, and then I become very humbled. So I appreciate all the work that you do. I've taken this information that is heavy. You could tell that you're a clinician, and you try and boil it down so that we can use it in our office. And that's what OEC likes to do. So thank you for presenting today.
Thank you, sir. I appreciate that.
Yes, thank you for doing this. And you are getting your virtual round of applause from the audience. Everybody really appreciated it. So with that, thanks so much, Chris. If you want to go get some shut-eye at 2 a.m, please go right ahead.
Yes, I will do that. I'll take you up on that offer. I'll have a couple hours of nap and then back to the grind.
Back to your Cochrane Library. I appreciate
exactly
that. So I appreciate that. That will wrap up our education, macular dystrophy, and more diagnosis and management. This was a synchronous virtual course. Thank you, Dr. Putnam, for doing this for us.
Absolutely. Thank you so much, everyone.